Next, we have a wonderful speaker. We have Dr. Shelby Kahl. Dr. Kahl owns an integrative dental hygiene practice in Fort Collins, Colorado. She initiated the concept and feasibility of co-locating dental hygienists into medical practices. In 2013, the Journal of Public Health Dentistry published the results of the Dental Hygiene Co-Location 1.0 pilot project in conjunction with the Children's Outcomes Research Program at the University of Colorado. Dr. Kahl believes the highest quality of comprehensive care occurs when professionals from different fields collaborate. Please join me in welcoming Dr. Shelby Kahl.
Thank you. So good afternoon. Thanks for your patience. I think we're going to do a sound check while I'm reading the AGD disclaimer. I do not have a financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. And just one more little thing, I am not a dentist or physician. I am a dental hygienist, and I appreciate that introduction so very much. So we're going to talk a little bit about this crazy pathogen called P. gingivalis and how it is implicated in the research with the human microbiome. P. gingivalis is something that we're pretty familiar with as far as the literature and that, or if I'm a periodontal patient or a periotherapist, it's something that I have on my radar anyway. But one of the things that I think I found unique about this pathogen is its spectrum of destruction and how it actually does that. It does it different than you think, and I'm hoping to shed some light on that this afternoon for you. So this is a look at how the pathogen Porphyromonas gingivalis impacts the human. The way P. gingivalis intrudes on the body is through more of a strategy than an actual physical implication. In oral medicine, it is imperative to identify what you're looking at, figure out what I'm dealing with, so that you can customize your patient protocols, especially utilizing special professional tools, maybe a team of providers to get the very best outcomes for your patient. So here's a little bit about what we know. Excuse me 1 second while I learn the tools here. Okay, so sorry, Dave. Well, I don't need to change the slides. I was just going to try to move up in the, and he was telling me, oh, hold it. Hold it. I am so sorry, everybody. 2 fingers. Sorry. Okay, 2 fingers. All right, 2 fingers deal here. So this is what we know. There is really good scientific evidence confirming that the oral cavity implicates the health of the cardiovascular system. That periodontitis creates a dysbiosis of the gut. Disease of the mouth contributes to diseases of the brain. There is new evidence suggesting that it could also be the reverse, that the gut dysbiosis contributes to the periodontitis of my mouth, and that the pathogens in the arterial wall may implicate me as a periodontal patient. And I don't know if it's so important to know, is the colonization of the bacteria first into the tissue, or is the tissue disease the part that triggers the colonization of the bacteria? It's the chicken or the egg, and I don't think it matters. What I think is significant is that we don't really understand the process of how we're getting where we're getting. We have a lot of research to suggest PG's here, PG's there, but we don't really understand the mechanism of how it's getting there. Whether one's looking at modulating the bioterrain or utilizing antibiotic therapy in patient care, there is mounting evidence that the processes are all linked together, that it is oral health is implicated in all the body processes. Porphyromonas gingivalis is a solid scientific link between the body systems and more. P. gingivalis can cause a host of damaging biochemical responses, and this is where I believe oral medicine is about balancing the patient homeostasis. First, we got to understand that we don't understand. We don't understand the complexity of the human microbial host interactions, nor do we really understand the microbial interrelated reactions that promote either health or disease. There are 3,000 years of history naming how the mouth has implicated the rest of the body. When I read that in a paper that was published like just 11 or 12 months ago, I was thinking, 3,000 years? Well, how did I miss that link? So the whole oral systemic link is amazing marketing right now, but it is not news. And as soon as we correlate what we know so intimately, the mouth and the health of the mouth, to the rest of the body and its processes, the better I think our patient outcomes are going to become. We don't have a one-size-fits-all protocol for patients. It's more about treating individualized patient, customizing, personalizing their oral medicine. I think we're at a point in oral medicine where patients are self-directed, thank goodness. I think that laboratory diagnostics are expanding, integrative dentistry and medicine are coming together to support all these patient outcomes that we need so desperately. So this is actually a genomic rendition of P. gingivalis. And what I think is kind of interesting is there's more than one Porphyromonas gingivalis species. So there's actually a P. gingivalis that is not disease-oriented. And many children end up with it. There's a study that suggests, they did in Japan, where the mom was tested for P. gingivalis and her children had it, but their children have the non-disease etiology forming of P. gingivalis. And it's actually, well, it's probably not important at this discussion here. Porphyromonas gingivalis is one of the superior pathogens that can cause microbial and immune dysbiosis. P. gingivalis pathogenicity is due to its ability to undermine and suppress the human host immune defenses. P. gingivalis is not a catalyst for inflammation. And when I learned that, I realized that's kind of what we're looking at when you have an implant fail. The implant looks great, soft tissue, isn't red, it's not inflamed, but my implant's failing. That's part of the process of P. gingivalis. It will cause implants to fail. It's going to camouflage the inflammatory response as well as backdoor into the immunity of the patient. PG can affect the innate immunity in periodontitis, the innate immunity in cardiovascular disease, the innate immunity in Alzheimer's disease, and it does this by modulating the inflammasome. The inflammasome is kind of a multi-complex protein, like a cytoplasmic complex. And it's here that the pro-inflammatory cytokines like interleukin-1, interleukin-6, they are all processed in the inflammasome, and apoptosis happens here. That's where the cell begins its life, does what it needs to do, and then it dies and makes an exit. So P. gingivalis has figured out how to modify these processes. So what I'm going to kind of mention now is more about Porphyromonas gingivalis, its influences and its characteristics. And this is maybe news that you already know about. More common knowledge about P. gingivalis is it's a gram-negative pathogen. It's pathogenic in low numbers. It doesn't do a lot to the biochemistry of the body when it's in a high number. So it's the low numbers, the chronicity of this pathogen that gets us in trouble with tissue. PG is a tissue invasive. It's invasive to the epithelial tissue. That's your gum tissue, our skin. It's invasive to the endothelial tissue, the tissue of the arterial vessel walls. And it's also invasive to the smooth muscle, like the muscle of the heart. It's also able to cross the blood-brain barrier. When PG is found in progression of chronic and aggressive periodontitis, it can create antibodies, thus creating a cellular memory. And this is going to be important in a little bit here. PG benefits when companion pathogens are associated, meaning as it opens up the epithelium and the endothelium, it kind of signals back to some of these other pathogens and says, hey, I got the gateway open, so come on in. This is why you find PG married with some of the other virulent periodontal pathogens. And once those pathogens are grouped, then there's more of a real celebratory celebration, and everybody's destruction periodontally is in place. PG is associated with atherosclerosis and cognitive decline. PG attaches to the red blood cells, the erythrocytes, and it causes this agglutination where the red blood cell gets super sticky. And this is due to the proteins that PG has, and as it cleaves those off, then things get sticky at the erythrocytes. P. gingivalis also decomposes immunoglobulins that are found in your gut. That's like IgG, IgA. This is one of the ways that P. gingivalis can influence somebody's leaky gums and leaky gut. P. gingivalis can break down collagen. It uses amino acids or proteins for energy. And PG is responsible for implant failure, like I mentioned just a moment ago. When and if antibiotic therapy is chosen, PG is sensitive to metronidazole or azithromycin. And that's really important to know if you're going to treat with antibiotics, that you treat with the one that's appropriate for the pathogen that's in front of you. So here's the not so good news if you're a dental hygienist or if you're a periodontist or a dentist that does scaling and root planing. P. gingivalis is non-responsive to mechanical therapy. It doesn't go away if I brush, floss, or home irrigate. It's not impacted by my amazing mechanical skills as a hygienist. Scaling and root planing does not cause P. gingivalis to go away, nor AA, T. denticola, T. forsythia, or P. micros. Those 5 pathogens are pretty virulent in the periodontitis sequence. So it's important to not think that we can go in there and bust through everything, manipulate the biofilm in a couple office visits or a series of office visits or in a maintenance phase. You're not doing that. You're actually exacerbating the host's response to having that pathogen in there. This is where I think it's important to realize, one, and thank goodness I'm limited. I need to call on other people in the healthcare community to help me manage patients, physician, osteopath, clinical nutritionist, all kinds of people that have other experience with managing the microbial influences of the body. Up above here is the graph, the purple, red, orange, green. Those are all, this is a actual testing of a lab. So what you get is a red grouping of high-risk pathogens, and this is PG, the red one is there. Then you have the moderate risk grouping and the low risk grouping in your salivary diagnostics. There are more than one company that does these labs, and when we're doing presentations up here at the IAOMT, we use these as examples, and questions later can come at the panel discussion on specific labs and recommendations. But once I do a salivary diagnostic and once I know what I have, then what I can do is figure out, well, PG is above that dotted line. That's the threshold. And the threshold for most people that read these labs, when you're new at reading them, oh, I'm just going to mess with the ones above the dotted line. Except for this group right over here, the Campno species group, which houses 3 different pathogens. That's the biofilm community in which many of the other ones even exist, especially TF and TD. So you really want to pay attention to the green group, the small group that doesn't really cause bone loss. It causes people to have bleedy gums when they floss, basically. Or if you do that little test that they're talking about out there where you rub the little proxy tip in between the teeth, chair side, and if it bleeds, they have they have this grouping most likely, or that's been my experience as I kind of empirically watch the data out there. I'm trying to learn what pathogens I have based on the clinical representation, and I got to tell you, I can't tell PG. There's no way, based on its stealth experience in the body. So what I do know about P. gingivalis, if I have PG and I couple that with one of the TDs or any of the grouping here in the high-risk grouping, I'm in trouble. I'm in really big trouble for cardiovascular health. I have more than a twofold chance that I'm going to have trouble with my heart. Whether I'm an athlete, running marathons, doing a lot of strenuous exercise, creating friction in the lumen of my vessel walls, and I have these pathogens, I am very highly likely to have some sort of incidence with my heart or vascularity. So if you couple PG with T. denticola, super bad combination. And if I couple PG with AA and T. forsythia, I'm also in trouble. So all of these groupings are here. Purple is AA, PG, TF, and TD. And then we have the green grouping over here that we'll look at here in just a moment. And this is back to where we were talking earlier about if PG can invade the epithelial or the endothelial lining and it calls on its buddies TD, TF, AA to come and coincide with it, we have a much bigger problem. These pathogens, P. gingivalis, is transmissible from the parent to the child, but it's not so transmissible from partner to partner, which I find very fascinating. And I think what we're going to learn pretty quick is it's the pathogenicity of PG to the child that is not causing periodontal disease yet. But we can find P. gingivalis in a child from a mom quite easily. But that PG in the child is non-pathogenic. So the other thing that I know about salivary testing for P. gingivalis is you're going to have an increased prevalence. If I have P. gingivalis, I'm going to have an increased prevalence for T. forsythia. I'm going to have an increased prevalence for E. notatum and an increased prevalence for T. denticola, So that is the upcoming research on the propensity of how much PG I'm going to have and what's going to accompany it. So again, we're back to P. gingivalis, its presence, and how it mechanically challenges the spectrum of my biodynamics and my infection and my modulation of my immune system. If I have these three, I have a high chance of type 1 diabetes. I think it's a threefold chance. If I have all three of those pathogens plus PG, I have a threefold chance of coming down with type 1 diabetes, which is implications in the pancreas. So if I have TF and PG, I'm going to implicate my brain health severely. And if I couple PG with TF and T. denticola, most likely I have an inflammatory response in my brain. So what's happening as a hygienist, what I'm seeing with these results is, am I really looking at poor flossing, poor brushing, or am I looking at somebody that has cognitive decline that doesn't have the dexterity anymore or remembering to brush and floss or whatever protocol I've got this patient on? That's the bigger, broader sense of the picture. It's not me just reading a lab. I can guarantee you it is far more in depth than this. It's cool to know this, and I'd highly recommend you do understand how to do these labs. It's super easy. It's a saliva test. It's a 30-second swish. Have them spit in a test tube. You mail it out. Your results are in 5 days. What's interesting with this testing is it gives me an insight to the patient who may not know they're even cognitively challenged. And I can tell you, there's 50% of us in this room don't realize we're cognitively challenged. It's not about forgetting where I parked my car. There's some other things going on out there that I'm learning the brain is implicated in so much more than we realize. So I put them together, PG, TF, and TD, and you can do a MOCA test, M-O-C-A. It's a quick, like 5 or 6 little points. Ask your patient. One of the things on the test is to draw the face of a clock. put 12 noon up high, 6 p.m., 9:03, and then draw the hands on the clock. Say, okay, draw like 3 p.m. on the clock. There are quite a few patients that can't do that. They might be able to answer the other questions, or in a series of 3 animals on the page, they can't tell which one's the hippopotamus. It's not that they realize they can't tell that, it's just that they've got a switch that just went off for a moment. So that's a bigger, broader topic, but what I'm trying to marry in here is these pathogens are implicating our brain faster than we're keeping up with the research. So the other part of salivary diagnostics looks at these immune markers. These are genetic inflammatory markers that you can figure out what a patient has. And then I have a propensity for that patient to be more sensitive to pathogens and have a bigger exaggerated response. Less gum tissue, less bone tissue, maybe a little bit of both. And there was a time when I can tell you how to modulate all these markers, but I've decided that's maybe the wrong strategy based on what I know now, and I'm about to tell you in a couple more slides. But if I know these genetic gene markers, these inflammatory markers, these are the markers, not the levels of these cytokines, these are just the markers. If I know these, and I can modulate my patient's immune system with this, then I may reduce their susceptibility to periodontal disease, their exposure to pathogens. But I'm only doing that if I know they are not modulating their immune system in other capacities with other providers. So it's the adaptive and the acquired innate, I'm distracted with this pen. So here's the innate immune system, and here's the acquired immune system. There's about 6 or 8 markers in this system, and there's 4 in this system. The test tells you all of them. So all of these are your immune system. The innate is the system you're born with, and the acquired or the adapted is the one that you create as you live your lifestyle. And P. gingivalis impacts both systems. The older information, which is about 18 months old, tells me that PG is modulating CD14 and toll-like receptors 2 and 4. This test actually looks at tumor toll-like receptor 4. So the adaptive or the acquired immune system and the innate system, they have this symbiotic back and forth feedback loops. One will modulate the other and pick up the slack for what the other one doesn't do. And it goes back and forth, kind of co-stimulating each other's systems so that we maintain this homeostasis in the immunity. The adaptive protection occurs in health, so that's also known as acquired. That occurs in health, but when you get periodontal disease, when you get cardiovascular disease, or if you get Alzheimer's disease, that system doesn't work as good. And that is what I think is coming up in the research, is what mechanism is actually causing that to happen. Sorry. Thanks for your patience. P. gingivalis has a number of enzymes and surface membrane proteins to suppress the action of these really tiny neutrophil recruiting cytokines. So it kind of goes through and erodes the cells, sort of scrambles the immune signaling, and then this mixed messaging starts happening between CD14 and toll-like receptor 4. So this messaging gets mixed up no matter my genetic propensity for being awesome, which, by the way, these alleles over here, that's the best lineup that you can have. But even though I have the best lineup, if I have P. gingivalis, those markers are going to get scrambled just because of the mechanisms I have as a pathogen of P. gingivalis. P. gingivalis antigens can undermine the adaptive immunity by downregulating the immune response. So it suppresses your T cells. All the while it's doing that, epithelium's being destroyed, the endothelium might be coming undone, and it could be crossing the blood-brain barrier. PG can suppress the adaptive or the acquired system, which is a protective mechanism for bone loss. So P. gingivalis can suppress all of these markers, which when you're losing bone, that's actually a good thing. You don't want your immune system hyperactive. You want it at a certain balance. Well, when you get PG in there, it can actually cause this response where, due to its chronicity at low numbers, it's chronically in the tissue, low numbers, it creates a cellular memory in which healthy tissue isn't available. The tissue only remembers chronic inflammation, chronic fibrinogen, chronic characteristics. So what we're looking at is a master pathogen that's able to modulate the immune system. If you have interleukin 6, which is right here, this allele here, the double G, you're either going to have a G or a C. The double G is the worst you can get for periodontal disease. You're definitely going to have bone loss, more exaggerated problems with your connective tissue. What happens here, if you have PG, if you have interleukin 6 GC, those alleles, you're more likely to have periodontal disease. And we're getting this data based on those of us that do these labs. We're collecting this data and we're figuring out, even if I just run the immune markers, I'm starting to be able to figure out what pathogens you're probably going to have, even without doing a pathogen test. That's pretty cool. That's data that we're collecting. So all this is a systemic process, and that's used to be what I had on this slide. I had systemic process up here, and I was reading some research called the bidirectional relationship with P. gingivalis. Well, I had a typo in there, and I put biodirectional process, and I kept it because I think biodirectional is really what this is all about. It's about helping manipulate the human so that we can have the best outcomes we have. And systemic health is this crazy system of relating or affecting the entire body. And as we're doing that, it's not a static process. Our biomechanics are all interrelated. And as a dental provider, we have this view. It's extraordinary. Not everybody gets this view, but I think when I only get to see this much, actually it's this much I'm looking at, I know in the literature that I have caries or I have periodontitis, I have pH balancing I could look at, osteoporosis, malnutrition, viral lesions, Crohn's lesions. I mean, the whole presentation could be about what you can observe in the mouth. But that's all we're doing. We're just documenting that I observed it. We aren't going further out in the sphere of helping humanity and saying, oh, well, maybe I should look elsewhere. If I have a Crohn's lesion in the mouth, is the patient got Crohn's? Am I referring them to their physician? If I have a viral lesion, am I even asking the patient about their viral load? Am I even asking the patient, are they breathing? Are they sleeping? Are they eating every day? Are they eating more than out of a box or a can or a sack every meal? Our view is pretty awesome, but we're missing it. We are not integrating what we can see clinically into the biomechanics of the physical body. And this is where, in this group, this information is like, you gotta be kidding me. I can't go home or go in Monday and walk through the office door and have that weight on my shoulder. That's the thing. It's not all ours. We get to share all this, finally. And the medical community is coming up and asking for help, and they want to support us. So what I'm going to do the next couple slides is introduce you to what we call the mind-body connection. So this is a pretty cool rendition. It's actually a marketing device by a dentist. So they have all the labels, except the mouth isn't labeled, the gut isn't labeled as having GI influences. So for a second, lose your left brain, here's your right brain, and I want to know, does everybody see the arrow in this marketing? So the arrow is right here. If you've never seen that, FedEx has an arrow. So little right brain stuff. Here's another one. Anybody see only one smiley and one G? Or do you see two smileys and two Gs? So here's my smiley. Here's a smiley down here. 2 G's, the letter G. And what about this one? Anybody see the Hershey Kiss candy in that logo? It's right here between the K and the I. So that's your right brain, just took a front seat to the left brain. This is what I mean about trying to get into a little bit more biodirectional relationship with just a single pathogen, P. gingivalis. It's going to impact the heart, the gut, and the brain. It impacts immunity. Got this great, amazing study coming up. It's actually in the process. Its primary focus is on the chronic inflammation and the role the microbiome has in systemic inflammatory disorders. Its focus is on the innate and the adaptive immune system, and it's looking at how microbial influences directs the innate adaptive immune system in chronic inflammation. P. gingivitis is implicated in GI health. There's more microbial cells in the gut than the human body. The gut genome encodes like 500 times more genes in my gut than there are in the whole human genome. That's just craziness. I can't even get that. I can't even say that. The gut houses our largest microbiome, which is like 2% of everybody's body weight. So your microbiome, the biggest part is in the gut. And in embryonic stages, form both the gut and the brain from the very same tissue. So when we're looking to try to evaluate how, if I'm trying to modulate my bioterrain, if I'm trying to use antibiotics as part of my patient protocols, the mouth and the gut are symbiotic. They have the same parallel influences with pathogens. P. gingivalis influences both the mechanical barrier of the gut wall and it affects the immune barrier of the gut. There are lab tests that you can run on your patients to figure out where their gut wall is, where their health is. And what's missing in this picture? Well, you got your right brain. We don't have a mouth up here. So PG creates and releases these lipopolysaccharides, which are known as endotoxins, and they exist on the outer side of the wall. Remember, every negative pathogen has a lipopolysaccharide layer, and that's what influences the gut wall. P. gingivalis is influenced in arterial health, and I was going to help you guys with some of the brand new research that just came out. They took these fat, obese mice. They opened up their maxillary first molars. They swabbed them in there with P. gingivalis, closed them up. 6 weeks later, they have P. gingivalis in their aorta wall. So this pathogen can get in and out very easily and very quickly. And there's another study just released like in July where they had atherosclerotic arteries, and they were looking in these healthy arteries of these patients, and these were actually athletes that had atherosclerosis, and they looked at their healthier components of their arterial walls, and they found PG in the healthy walls. So that kind of asked the question too about the child transference from the mom. So in some instances, maybe PG is normal. In some instances, it's destructive. We have P. gingivalis in cognitive health. It's implicated in cognitive decline. It's the small amounts of PG that cause the most damage in the brain. P. gingivalis has this effect on amyloid plaque. Amyloid plaque is actually a defensive mechanism of your brain. It actually helps it. But when P. gingivalis gets in there, more plaque is produced, and you come out with a wrong response with the amyloid plaque. So the other thing I wanted to tell you is P. gingivalis affects the brain through the cardiovascular system. If I have periodontal disease, I unload that into my arterial walls. That frays the endothelium, causing the P. gingivalis endotoxins cross the blood-brain barrier and end up in my brain. And maybe at the same time it crossed my gut wall barrier too, so I've got trouble no matter where I look. The point of this is There are linear charts you can look at, the microbial influences back and forth through the cytokines, grabbing an immune response, creating some modulation in the host, and you ultimately come up with a diagnosis. Or you can also look at periodontal disease from the top down. You can get these linear graphs. This is periodontal disease, the lipopolysaccharides, creating a systemic imbalance. And you transport these ultimately in this graph down into Alzheimer's disease. The deal with that linear stuff is it's not linear. It affects my head, my mouth, my heart, my gut, my arteries. This is a spherical response. And as you step back and recognize there is a Hershey's Kiss in the logo, that's where I need you. And lastly, I'm just going to mention there is a cell danger response paper written by a pretty brilliant guy, I think. His name's Robert Navio. He's a PhD physician in California. He's got this paper called The Cell Danger Response. And in that paper, it has helped me understand that I don't really understand what's going on based on my education as a dental hygienist. Even based on the education I put myself in front of functional medicine groups, integrative medicine groups, biophysics, neurophysiology, the cell danger response is super crazy simple. If you leave it alone, it's going to fix itself. Our body has these amazing mechanisms to fight and heal and regenerate. But what's happening right now is that we are so good at recommending anti-inflammatories, squashing the inflammatory response, as well as encouraging the patient to upregulate their immune system. What happens is there's this process where as I squash the inflammation down, raise my immune system, I get this crazy response, and it's called a histamine response or mast cell response. And it's this histamine response that I think you're looking at when you have an implant fail. The tissue looks good. They're doing their home care. They got 0 plaque score. They got nothing going on to tip me off they were going to lose that thing. But that's what a histamine response is. So it doesn't show up clinically. It doesn't show up on a radiograph, but my patient's complaining. They're anxious. They're upset. They can't get comfortable. A lot of this is based on this paper here, the cell-dangered response. To remedy this, it's nutrients, it's micronutrients, it's macronutrients, it's supporting methylation. It's looking at more of allowing the host, my body, to do what it's asking to do versus me interfering with it. It's a metabolic response is what it is. So when we're looking to personalize our oral medicine process with patients and impact P. gingivalis in a patient, I think we can do this based on basic things. I think we need to take a patient history intake, including a timeline. We need to ask them if they're sleeping good, if they're eating good, if they have can they sweat, can they pee, can they have bowel movements? All those things are the silliest questions you had to ask in a dental office, but it impacts how I can treat this patient differently, whether I'm modulating their system or pre-treatment strategy before my periodontal therapy. Is that with upregulating their immune system, IV vitamin C, ozone infusion? Is that doing that before my mercury revision, my extraction process? These things are part of what I think is important. Topicals, absolutely. For managing the biofilm of P. gingivalis, there's a lot of great things out there that we could discuss at another time. And I think the last thing that I'd like to mention is the more information you have to bolster the patient's response to your care, whether that's biofilm disruption, safe administration of chemotherapeutic agents, remembering to ask them about their lifestyle. Are they smoking? Do they drink every night, every weekend? Where do they live? Do they live in Colorado where we mine coal? Do they live underneath an electric power plant? What's their nutrient density like? It's not so important what diagnostics you use as it is to diagnose what's sitting in front of you. Thank you for your time.